Okay. Good morning, everybody. We have a lot to go over. Phil asked me to talk about adrenal neoplasms, which I am not an expert in. So I called in the best backup I can think of. Joining us today is Dr. Graybill from endocrinology of Graybill and Graybill. You may know and work with her husband a little bit more, but hopefully you get to work with her as much as I have gotten to work with her over the last 3 years. But she's been very helpful for me in taking care of our endocrine patients, particularly our adrenal patients. My talk for today, we're going to go through some biochem PTSD. Sorry, you can't talk about endocrinology without undergoing some biochem PTSD. We're going to talk about normal steroidogenesis. We're going to gloss over that because, quite frankly, there aren't many surgical diseases for the congenital problems that deal with steroidogenesis. And then catecholamine synthesis, because this plays into how we work up our patients, how we work up the various tumors, how we manage the various tumors, and then particularly post-op, because these are rare things and you need to know what to expect after you remove a hyperfunctioning adrenal, how that's going to influence your patient's post-op management. So stuff we're going to need to know for all this, of course, everything. You don't need to know everything. But when you're cramming for your ABSITE, you need to know your pathways. You need to know your feedback loops. At least 1 to 2 meds to control each, I shouldn't say all, but each of the tumors, because there's not one med that controls them all. It's not the Lord of the Rings. And then basic imaging features. And we're going to go over a lot of imaging today as well. As you know me, first things first, though, let's talk about some history. So we've been dealing with adrenals for a long time. In 1855, Dr. Thomas Addison publishes on 11 patients who have adrenal destruction from tuberculosis and then hemorrhage and other things like that. And something that was common between them is many of them had hyperpigmentation, hypotension, chronic abdominal pain, a complex that we learned to be called Addison's syndrome. In 1890, the first quote-unquote successful adrenalectomy was reported for a giant androgen-producing tumor in a young woman. It's most likely an ACC, an adrenal cortical cancer. These things produce sex hormones at a higher rate than the other tumors. She died 2 years later, which is why we think it's about ACC, because they're also ugly tumors. In 26, Cesar Roux, all right, third row, Spencer. Where was Cesar Roux? Yeah. What kind of a surgeon was he, nationality-wise? Please reference prior Krell-Toxon Roux limbs. Swiss. Which is like France. Performs the first adrenalectomy for a pheochromocytoma. The following year, the first US adrenalectomy for pheochromocytoma was performed by the first picture on the right. I need an Army person to answer this question, because an Army person should know this. Liv. No. The top picture. The surprised-looking person wearing an Army uniform. Custer? I would say, although, you know, I think a pheo, the first pheo without alpha blockade would be kind of a Custer's last stand situation. That's Charles Mayo of Mayo, who was also one of the first Army generals in charge of AMED. So know your history. The Army has a rich history of endocrine surgeons in charge of things. And then let's see, flash forward to the 30s, Cushing's disease was treated by bilateral adrenalectomy. Harvey Cushing is the moniker for that. In the 1940s, cortisol was synthesized, garnering its synthesizers a Nobel Prize. So a lot of the endocrine discoveries have garnered Nobel Prizes in medicine's physics. In 1950s, the most common reason we performed adrenalectomy in this country was to treat breast cancer. It's kind of weird, but let's think about that for a second. Connor, when was the first chemotherapy used for breast cancer? When was it discovered? Fluorouracil was one of the first mainstream chemos that we used to treat all kinds of tumors. It was in the late 50s. So before we had chemotherapy, we had surgery. And so we had learned that removing ovaries and adrenals was more effective for preventing progression of metastatic breast cancer than anything else that we had at the time. What about tamoxifen? Hormone blockers, which become one of our most. When was tamoxifen hitting the market? Late 70s. So before we had any medicine, all we had was surgery. And so for a very long time, adrenalectomy was a very standard treatment for metastatic breast cancer. And then finally, in 1955-6, primary aldosteronism was described and treated with an adrenalectomy. It was a urologist who did the adrenalectomy. Sorry, we can't claim that one. And who is the person on the bottom right side, George? This is when you're going to play to your audience. I'll give you a hint, the blue background is important because this institution's pictures all have that blue background. There's Jerome Kahn. So we have the name Kahn syndrome. Jerome Kahn was a medical endocrinologist and the chair of medicine at University of Michigan for a long time. Enough history. Okay. Steroid pathways. Just need to know all of that and you'll be fine. Just all of that. First things first. Whoop. Oh no, there we go. Oh, out of it. No, it's still there. Sweet. Starts with cholesterol, goes through a bunch of modifications. There's some important enzymes that if you lack them from a congenital cause will shuffle you down other pathways into various clinical pictures. The mineralocorticoid pathway occurs in what zone? This is like a med student question. What zone of the adrenal cortex controls mineralocorticoids? Glomerulosa, the G. So this is depicted to go down this way. This is mineralocorticoids, aldosterone being one of the final common pathways of that. You go to a different zone next to the medical student down the road. Which zone is this? Fascicularis, G, F. And then finally, if you get into the deepest zone, reticularis, you get androgens, sex hormones. The moniker is the deeper it goes, the sweeter it gets. I did not make that up. If you knock out these, so 17 hydroxylase is one of the major ones that shuffles from mineralocorticoids to other things, or 21 hydroxylase, which shuffles a lot of things down. If you knock one of those out, bad things happen. So 21 alpha deficiency, classic. There are various forms of this, and I didn't even go into these because, quite frankly, I'm a surgeon. You can't operate on this. Aldosterone goes down, but it's eminently testable, which is why we bring it up, right? So you knock out your mineralocorticoids. That's just out of there, for the most part. Aldosterone goes down. Compensatorily, renin goes up. Cortisol goes down because you've knocked out your ability to convert 17-OH progesterone into all that stuff. Testosterone goes way up because you're shuffling your steroid hormones down the pathway into sex hormone production. And ACTH goes way up because one of the main regulators of ACTH is cortisol feedback. So these people have high ACTH, which also kind of puts them in this self-destructive cycle because it does stimulate the rest of this stuff to occur. If you knock out 11 beta, so you get down some mineralocorticoid, some glucocorticoid, but still mostly shuffling down into the testosterone and sex hormone stuff. Similar picture, ACTH goes up, aldosterone still remains down, renin remains down, cortisol remains down. And then finally, whoops, sorry. And then 17 alpha deficiency, they get really bad hypertension because everything's been shuffled down the mineralocorticoid pathway. This may show up on tests, particularly like steps, not so much your absites, but I bring this up because you got to think about this. Pathway loops, two important ones we have to think about, renin and aldo. So renin gets released by the what? Still a first row question. Kidneys, yay. And what's the main stimulus for renin? Use all your clues. Yeah, kidneys see decreased blood pressure. They say we need to make more renin. It's more complicated than I know, but we'll keep it at that level for the surgeons. Renin goes in the bloodstream. Liver makes angiotensinogen. Renin converts angiotensinogen into angiotensin 1, goes to the lungs, angiotensin 1, angiotensin 2. There are medicines that block that. Second row question. Use all your clues. The ACE inhibitors. So that's where the ACE inhibitors' main mechanism of action is. That's why you get a cough. And you think the captopril cough, for example, because its primary site of action is in the lungs. I have no idea if that's actually true, but that's what we see. Angiotensin 2 finally makes its way to the kidneys where we increase aldosterone production. And aldosterone sets the cycle. So this is all in some of a dynamic equilibrium. Maintain, what is the end goal function kineo? Why do we have this loop? Mostly volume, yeah, pressure and volume. Catecholamines, what you need to know here is at the bottom. So you start with phenylalanine and tyrosine, it goes through a bunch of changes. The inputs are norepinephrine, which gets converted to epinephrine by this PNMT enzyme. PNMT is found in 2 specific locations throughout the body, Spencer. And where is the organ of Zucker candle? Yeah, somewhere we always say it's near the bifurcation along the takeoff of the IMA. It can be anywhere up and down the aorta. So those are the 2 primarily sites of chromatin tissues that express PNMT, which tells you if there's a tumor that's making adrenaline or epinephrine, norepinephrine, maybe it's in one of those spots. Not hard and fast, but of course, that's what we like to teach for testing to keep it simple. And then spontaneously, those hormones undergo O-methylation, which is some kind of chemical process I don't understand. But the end result of that is the metanephrine. So when you hear metanephrine, normetanephrine, it's because these chemicals have undergone O-methylation. Why that is important is because this stuff is cyclical. The metanephrines is kind of continually produced by any tissue, which is why we think metanephrines have higher sensitivity specificity as a screening test. Okay, normal. Keep this in mind. This is cortisol. Cortisol gets made by the adrenal glands, goes up, suppresses a little bit the hypothalamic release of corticotropin releasing hormone, and then the pituitary gland for adrenocorticotropic hormone, and that's the feedback loop. Dexamethasone acts on both the hypothalamus and the pituitary to suppress that. This is the basis for a lot of our testing for cortisol abnormalities. It is also secreted cyclically. So your highest cortisol levels are in the morning. We use that for our cortisol testing. Great. Whoop. A quick note on labs. Reference values vary by the lab, by the hospital, by the lab. Cutoffs have different sensitivities and specificities. There's no one gold standard test. We're going to go into that for a lot of stuff, and this is what causes a lot of problems for us when we're working these patients up. You have to know your lab, your cutoff values, and the sensitivity and specificity for that. And gold standards, more guidelines than rules. So first, quick physiology check. Cortisol up. This is a second row question. Liz Reynolds, cortisol is up. What is that? No. What is the syndrome associated with hypercortisolism? Cushing's syndrome. Okay, good. Corticotropin is down. ACTH is way up. Dex still suppresses the cycle. And that's called, it's Cushing's disease. Cushing's disease, pituitary adenoma making ACTH. So the tumor makes ACTH. Whoop, tumor makes ACTH, increased cortisol production. Dexamethasone can still suppress the tumor a little bit though, so you see a suppression in the cortisol levels, even in people with that. Falco. CRH is way down. ACTH is way down. You don't get much suppression when you give them dexamethasone. Yeah, adrenal Cushing's. Exactly. So the adrenals are the problem. They're the ones that they have escaped feedback from they have some ACTH. They can always like do some of that, but they've kind of escaped the cycle. So you give them dexamethasone, it's not really going to help that because the problem isn't at the pituitary or the hypothalamic level, it's at the adrenal level. So this is the basis of our dexamethasone suppression testing. We can help figure out the difference between these two entities using that. Okay, sorry, back. CRH is way down. ACTH is way up. No myelin suppression. Malignant pituitary? Yeah. What is more common than a malignant pituitary tumor? Yeah, so ectopic ACTH. The two most common things are lung cancer or other neuroendocrine tumors. A common board question, let's see, Connor, back row. Another endocrine tumor that can cause ectopic ACTH. That's in the endocrine realm. So one that, yeah, I've seen this several times only because of where we train, but medullary thyroid cancer. Medullary thyroid cancer is a neuroendocrine tumor of the thyroid. It can make ACTH, and metastatic medullary thyroid cancer, they can have a Cushing's picture, and that is treated with bilateral adrenalectomy. Seen that twice total ever. Okay, going on the road. Is it Goeri? Goey. CRH is way up. ACTH is way up. Cortisol is down. Yes, adrenal insufficiency, Addison's disease. Okay, moving on to a different one. Second row, or actually, Jay. Renin is down. Aldo is way up. Primary aldosteronism, also called Conn syndrome. Oh, dang it. Well, there you go. 2/3 of it, bilateral hyperplasia. Sorry, I was supposed to hit you with the double bonus. 2/3 bilateral hyperplasia, 1/3 unilateral aldosteronoma. That comes in important later on in the talk. Okay, George, renin is way up and aldosterone is way up. Yeah, you can have renin secreting tumors, but we just call it secondary aldosteronism because the differential is rather large. And for, let's see, yeah, Jamie, what would you want to check for as something that like a structural cause of secondary aldosteronism? What could be causing this renin to go way up with an expected increase in aldosterone because the cycle is working? It's just we're tweaking it at the renin level. Yeah, exactly. Renal artery stenosis. is the big one. Bilateral renal artery stenosis. The kidneys see a relative hypoperfusion because of the renal artery stenosis. They increase their renin. So the body tries to jack up its volume status to overcome that renal artery stenosis, and that can put them in this vicious cycle and difficult to control hypertension. And then various genetic issues, which again, we can't operate on, so we're not going to talk about it. All right, imaging. This is one of the main reasons these patients come to our attention. Particularly the trauma service, and ACS is great for this because everybody's getting scanned and they're like, now there's something in the adrenal gland, what do you want to do with it? So first things first, let's do third row. Meg, how do you interpret this image? This is obtained for a lady with vague abdominal pain. Those little guys, would you wear those? Yeah, those are the little guys. Those are normal adrenals. This is what you want to see on these scans. You want to look up high. You want to look up by this muscle right here. This is a first row question. What is this muscle that's curving around the aorta right here? Yeah, it's the diaphragm. It's not just the diaphragm. You need a diaphragm to live. It's an important muscle. So this is what a diaphragm looks like on cross-section. It looks like this big thing that's, it looks like this thin little wispy thing that's wrapped around the aorta going around the side. So high up near the diaphragmatic cruce, that's what this is, the diaphragmatic hiatus for the aorta. You see these little lambdoidal structures or Y-shaped structures. Those are the adrenal glands, surrounded by a bunch, and depending on how much fat the person has, surrounded by a bunch of intra-abdominal retroperitoneal fat. But what you're looking for is these. They look like Ys or Ls or something like that. They're thin, they're uniform thickness. Okay, this is why most patients get referred. So, Pat Thomas, it's a little bit hard to see here, but what do you see? Good, yeah, so I don't know why that didn't come. Oh, this is the PowerPoint version, isn't it? That's fine. So that's an right adrenal nodule. Small levens are nodules. It's a left adrenal mass. Bigger things are masses. That was actually the right side's lining wheel, which we'll talk about in a little bit. That was his CT. That's lining. So again, they're high, but they look like generally a hyperdense thing near the top of the kidney on either side. Remembering the right side is going to be a little higher than the left side just because of the anatomy. Scratch that. The right side is generally a little bit just between diaphragm and aorta. So on the right side here, there's a little wisp of this patient's right adrenal gland, one of the limbs of it. But this is the mass, well circumscribed in this particular case. But that's what they're describing. Nodule, mass, nodule, mass. Okay, cool. So first things what? So I would say a little bit more structure. So symptoms of hormone excess or metastasis. Remembering adrenal mass is the other most common adrenal mass is metastasis from somewhere else. So going down the list again, Annie O'Shea, fatigue, depression, weight gain, bruising, diabetes. This is a constellation. Yeah, so Cushing's, Frank, panic, headache, palpitations, hypertension, Theo, good. Justin, poorly controlled hypertension. They're on 3 or 4 meds. It's just, yeah. That seems to be, depending on the clinic you go to, a lot more common than we thought. So like the Mayo Hypertension Clinic, where people just like are having trouble controlling their blood pressure, up to 20% of their patients have Conn syndrome. Let's see. So Bobby already went through there. Back row now, way in the back. Cancer history, weight loss, bone pain, hematochezia, hemoptysis. Cancer. Yeah. So what? Yeah. So which is the most common metastatic adrenal cancer? Lung cancer. There you go. And then family history, again, sudden death and cancers in the face. There are some familial cancer syndromes with which adrenal cancer is highly represented. That's Lee-Fraumeni. You're not going to see those patients most likely over the course of your career. Just know about it for your testing. P53 mutations, adrenal cancers. On exam, what are you looking for? Basically all the same things, right? Central obesity, weakness, striae, that's signs of hypercortisolism. Hypertension, if they have an echo with left ventricular remodeling, that could be a sign of aldosteronism or longstanding Theo. It depends if they have like kind of like a low grade Theo that's been kind of pumping out for years. And abdominal mass, usually not a good thing. So endocrine tumors are usually really small. They cause problems because of the hormones, not because of mass effects. So if you're seeing an abdominal mass, then something else, right? Okay. So then, okay, we talked to our patient. We've done our physical exam test. Let's get some hormones, right? We have to see whether this is a functioning tumor. So Fahey, what is our Theo screen? Urine or plasma. Yeah. And remembering back to what we said earlier, the metanephrines are a little bit more consistently released because that O-methylation process is like, it's just a constitutively active thing. It's not regulated by ACTH stimulation or whatever stimulation of the adrenal glands for that to happen, which is why we think it's a little bit better than dopamine, norepinephrine, epinephrine as a screen. Primary aldo, Lexi. Yeah, renin and aldo. Plasma and plasma. Let's see. Back around to the front side now. Liz Reynolds, adrenal Cushing's disease. Yeah, so we do it consistently in the morning because that's where you get the highest level. But what else are you going to do besides measure their morning cortisol? You do want to measure their morning cortisol, but would a random morning cortisol tell you much? Unless it's like sky high. If it's sky high, sure. But even then, yeah.
It doesn't screen out.
Yeah. Yeah. So you want to influence that cycle, right? You want to tweak that feedback loop for something that helps it. And that's the dexamethasone suppression test. When I say low dose, Justin Slater, how low is low? 1 milligram. So there's different levels of the dex suppression test. And this is when it gets into the weeds. And we'll get in the weeds in a second. We use 1 milligram. I use 1 milligram at least. There are others. There's a 2 milligram. There's a 2-day, all that. I use the low dose overnight dex suppression test as my screen. And then we'll go into how you interpret some of those things in just a second. And then other hormones of interest, Connor check, depending on the clinical scenario. So we've ruled out most of the things that the adrenal needs, except, yeah, you can. And I get a DHEAS. Again, you don't have to do that. That's how I was taught. But if androgens are elevated, Phil Kemp, what does that raise suspicion for? Yeah, an adrenal cancer. Again, they're a little bit more enriched for the androgen production. In the military system, it's free, so I get it anyway. And again, like this is how I start. You don't need to get those, but if you suspect ACC, get it right off the bat, just so you have something, because you can follow that as a tumor marker down the road. Yeah, so then a word about biochemical tests. Now we talk about have a friend in endocrine, because after all this stuff comes back, there's a lot of nuance in it. Did the patient take the stuff at the right time? Did the lab draw it at the right time? All those things, and quite frankly, like it can vary all over the place. Mind the reference values. Patients' bodies haven't read the textbooks. You can see different hormonal abnormalities as secondary or tertiary effects. For example, we had a lady, and we'll show her with a FIO. A part of her FIO was she was, because of the chronic stimulation, she was like so chronically stressed from her FIO that she had a mild Cushing's picture, just from adrenal cortisol production, secondary to her FIO. So if you get a screening test, want high sensitivity, confirmatory test, high specificity, that's just again for absite, like GIVA stuff. Sensitivity, you catch more, specificity, you rule out. Okay, many things mess with the lab testing, right? So FIO, anything that can jack up your body's normal stress things, so including coffee, not the caffeine, although caffeine can kind of do it. There's other things in coffee which can raise your plasma metanephrine levels. Tricyclics, so antidepressants, if you're on decongestants, so all of you Sudafed huffers, stop that. And reserpine, sorry, public service announcement, stop that, please. For dex suppression, there's all kinds of things that can get in that. So oral estrogen supplementation, exogenous steroids. So when you're deployed, like guess what? They're all juicing, and that's going to get in the way of that. Alcoholism, active pregnancy, chronic active hepatitis, if they have a FIO. For Conn syndrome, a lot of things don't interfere, it turns out, or some things with Conn's, again, like they actually kind of help the sensitivity of the test, but consistently, if they're on beta blockers or clonidine, it can give you a false positive because there's a compensatory aldo release in that situation. False negatives, anything for the dex suppression test, again, anything that increases your body's metabolism of dexamethasone. And that's if you're on if the patients are classically on anticonvulsants or something like that, stuff that ramps up, or like long-term smokers, I would guess, for maybe a similar reason, I'm not sure. But anything that ramps up your hepatic metabolism of drugs, they'll do that. And then false negatives on cons, if you're actively blocking the angiotensin axis, I can give you a false negative screen too. Low dose dex suppression test, like we talked about, that's my initial screen. 1 milligram dex at 10 to 11 o'clock the night before, and then you say, come to the lab and get your cortisol, get your labs drawn at as close to 8 as you can, just to keep it standardized. And there is a lab test, AM cortisol. I don't know if that actually tells them to draw it at 8 o'clock, but at least it helps give you more leeway in saying, like, look, lab, I said I wanted it in the AM, right? So the cutoff at that is where the meat of all this lies. So if they suppress to less than 5, or if they don't suppress to less than 5, I guess I should say. So if their AM cortisol is 5 or higher, that's used in many old and mostly surgical studies to say that's a positive screen, meaning that they have hypercortisolism of some sort, either clinical or subclinical. The more recent guidelines, particularly the endocrine guidelines, really like to see less than 2 and specifically less than 1.8, which is at the very bottom level of the assay for many places, but that's high sensitivity signaling. They suppress to less than 2, so basically undetectable cortisol level, they don't have Cushing's. Now, if they're between 2 and 5, They may have subclinical, there may be a problem with the test, there may be a problem with the way you gave it to them, all those things. But for a majority of our literature, it's 5. You shouldn't hopefully get tested on this level because it's somewhat controversial. You can do a 24-hour urine-free cortisol, also works, or a midnight salivary cortisol, generally ×2. We have a couple patients now, like real world examples. So this is the lady with an incidental nodule. So she screened for everything that she had going on in her life. Like this, I interpret this as a normal screen. So we're gonna leave her alone. Of importance is the dexamethasone under the miscellaneous send-outs, because this is something I hadn't been doing, but at the advice of our endocrine colleagues, I start doing now is send a dexamethasone level in addition to your labs to make sure they've metabolized it, or if they've metabolized it too far. That 373 is well above what it should be at 8 o'clock. So this says like she has dex in her system and she didn't metabolize it too quickly. So we interpret this as like, okay, she had dex, she's suppressed, she's less than 5, she's got bigger issues going on. So we're gonna leave her adrenal alone for now. Normal-ish. Yeah. So AM cortisol. So this is someone that did an overnight dex suppression test. Liz Reynolds, how do you interpret this? Yeah, it's abnormal. It's inappropriately normal. They don't suppress. And so this is, some people figure out. So if you see like an 8, they're like, oh, that's great. It's like the low end of normal. Like, no, it's not the low end of normal. In a normal person, it should be undetectable, right? So if you see an inappropriate, if you see a normal level on a dex suppression test, assuming they did the test, right? That is a positive screen. Yeah.
Sure. If you go back to that 8 to 24, that's like the lab parameters they can detect between this and this.
Yep, that's their normal. That's the normal 0800 cortisol level in a functioning human being. So if we're manipulating that cycle by giving them dexamethasone, this should be undetectable. And we have several patients where like this is screen out. You'll see it eventually when you get your trauma. If you have a trauma patient that has one of them and you come to clinic and you do this, their AM cortisol will be less than 2. You're like, great, you're good to go. In the interest of time, so this is a salivary cortisol, which is abnormal. This is Liney's, I think, again. So so the levels, again, mind your reference values. The levels are really important. So 0.202 doesn't make sense until you learn the lab is like exposed to be less than like 0.15 or something like that. Okay, so this is a patient with, yeah, meta-nephrine screen. Bobby, what do you think? Very high. And so FIO's pretty easy. So this one, you say like, do we have to do a lot of confirmatory testing? Generally not. If it's 3 or 4 above the lab reference, they've got FIO. Yeah, Clifton patient. So let's see, Kat Thomas, how do you interpret this? Is it a high aldo? High aldo, and is the renin detectable? Okay, so the ratio is probably higher than 20, and the aldo is definitely higher than 15. So they've got cons. So confirmatory testing, Cushing's, like at some point get a plasma ACTH and call an endocrinologist. There's all kinds of things we need to do to figure it out, and you need multiple confirmatory studies to make sure that that's the case. Best directed under the guides, under the aegis of an endocrinologist. If they have cons, the salt load test, that's great. So you either tell them to eat like a tablespoon of salt and like chips and pickles and stuff like that for 3 days, and you get a 24-hour urine collection, or you bring them into the hospital and give them 2 liters of saline, rapid infusion, then check their plasma aldosterone level. Neither of these are pleasant, but you can do either of them. Or the so-called Catecholamine test, which I don't think anybody does. Yeah. FIO, get clonidine suppression if it's an unclear case. Remember, most of them are pretty clear, and then get genetics and start alpha blockade right off the bat. If you suspect FIO, you want to start treating FIO. Sneak attack. Kyle, which genes? So everybody with FIO gets genetic screening. For sure, these 4, there's multiple, but for sure, these 4. The SDA, RET, if they have a RET mutation, what else should you be screening for, Liv? Yeah, medullary thyroid cancer, von Hippel-Lindau, neurofibromatosis. These 4 genes for sure. There are other genes as well. And when you come to us, our genetic screening packet has like the endocrine tumor panel that we send out for them. Multiple hormones are elevated. Phil. Yeah, get nervous. Most common hormone secretion in adrenal cancer, Justin Sleater. It's actually cortisol. It's the other problem too, like you really want to figure this stuff out because ACC is the most common hormone they produce. If they're producing hormone, it's still cortisol, but they also produce multiple hormones. And if they're producing multiple hormones, that should raise your suspicion that you're dealing with an ACC, adrenal cortical cancer. All right, imaging real quick. CT adrenal protocol, like all their whatever protocols, it's really just running through the patients at multiple times. So they run the patient through unenhanced. They give them a shot of bolus. They run them through again. They wait 10 to 15 minutes. They run them through again. That's really all it is. When we said we want the whatever protocol. If it's less than 10 Hounsfield units on an unenhanced, it's benign, with almost no exception. If it washes out more than 50%, it's also benign. All right, Phil Kent, who's on the right? What was his first name? So Goddard, Sir Goddard Hounsfield. And where was he? If he's a Sir, yeah, Great Britain. And what kind of a doc was he? No, he's an electrical engineer who won the Nobel in medicine for inventing the CT scan. So you too, no matter what you do, you can get a Nobel in medicine, it turns out. MRI, I'm going to tell you right now, I don't like MRI adrenals. This is personal preference. I was raised on CT, and I find MR adrenals pretty hard. And when you look at the literature, at least, MR for adrenals is really only good for ruling out a benign gland. There's a lot of overlap in all of the tumors and how they appear on MRI. However, if you lose signal on a post phase, that's the bottom right picture, and it's darker than the spleen, then it's benign. So that's the one thing for MR that's helpful. If it drops out signal on a post phase, it's benign. Falco, this is your standard scan. This is a non-con CT. It's negative 12 Hounsfield units, and the patient a normal hormone screen. What are you going to tell them? That's a win-win. That's totally benign. You say, congrats. We have to keep an eye on it based on its size, but we have to do nothing for you right now, except keep an eye on it. Okay. Jamie, pre-contrast, this lesion was 90 Hounsfield units. Post-contrast, it shows heterogeneous enhancement. The patient has palpitations. Correct. FIO. So FIOs are very heterogeneous imaging things. They can look like anything. That's the problem. But most commonly, they're bright. So they have high Hounsfield units on unenhanced, and they enhance and definitely pick up contrast. But they can be heterogeneous. They can have calcifications. They can have central necrosis looking areas. So they can look really ugly. But at the end of the day, you go by their symptoms plus what you're seeing on the scan. This is adrenal CT on, oh yeah, this might be Mr. Neal. So let's see. These are real deal numbers. Non-contrast, 16 Hounsfield units. So is it benign off the cuff? Is it benign off the cuff? No. So he gets contrast. It goes up to 99. On delays, goes down to 44. I wouldn't. So remember, less than 10 is benign, but then how much washout is also benign? Yeah, so it's more than 50%, right? So this is the so-called lipid poor adenoma, just meaning it has a little bit less fat than your totally benign ones that are less than 10 on the unenhanced. But this is also a, congrats, good for you. We'll just follow it over time. Okay, Carson Ward, you got this one. Big, ugly, it's invading the liver. What do you think this is? Yeah, it's cancer. So the adrenal cancers tend to look big and ugly when they're at presentation because they behave like sarcoma. And for the purposes of this talk, because we're running out of time, when you hear adrenal cancer from a clinical management standpoint, kind of manage them like sarcoma. And that you stage them and you do big wax to get them out. Macroscopic fat Stegall. It looks like that fat. It's the same fat right there. It's like an adrenal tumor that's just full of fat that looks like retroperitoneal fat. What is it? Yeah, a lipoma of the adrenal gland, a myelolipoma. This is diagnostic. It's really helpful when you see this. If they have macroscopic fat on CT or an MRI, it's almost always a myelolipoma. Is that benign or malignant? It's almost always completely benign. These are incidental findings that cause a lot of consternation. So do I need to fix it? FIO? Yes. Cons. Yeah, so do I need to fix it as a surgeon? Maybe. And we'll get into that in a second. Adrenal Cushing's. Justin, yeah, probably. The data we have suggests that there's increased long-term mortality and morbidity with untreated adrenal Cushing's. What about subclinical Cushing's? Yeah, maybe. Long-term bone, again, the data aren't very good, but there seems to be a decreased risk of long-term fracture and long-term cardiovascular comorbidities. Adrenal cancer? Frank. Yeah, if you can, right? Myelolipoma. Any O'Shea? No. Good. So for treating Cushing's, so this is where the controversy happens. It turns out, like most things surgical, we do a lot of things based off sound judgment and physiologic. It makes sense to us, but when we actually study it, we see different results. So for things you need to know, someone comes to you with subclinical Cushing's. What's their risk of progressing to overt Cushing syndrome, like getting really sick from it? It's actually less than 5%. So people with subclinical Cushing's tend to just stay subclinical over the long term. The cohort data suggests there's increased cardiovascular, diabetic, and bone morbidity if they're not treated, however. They haven't really ran, there's one really underpowered study, and all of the adrenalectomy studies are underpowered. Like the maximum study size of a randomized trial is about 25 to 30 patients. So take all this with a giant grain of salt. However, it looks like adrenalectomy is associated with fewer long-term bone fractures, particularly new vertebral fractures. And it's the only chance to biochemically normalize their hyperglycemia from the diabetes and make their blood pressure better. Can you hang your hat on it? Of course not, because we don't have that kind of data. Cons, got to find one gland. Bilateral hyperplasia is the most normal thing. This is when we do adrenal vein sampling. That's interesting. Looks like a rune. Okay, what they do is they put a catheter into the groin, they feed it up into the adrenal veins, and they give the patient ACTH, and then from the adrenal veins, they take both cortisol and aldosterone levels. And the reason they do that is because the left adrenal vein has different anatomy than the right, and so you have to normalize it to something, so they use cortisol from the adrenal on both sides. This is why we do it. Montel. So can you interpret, yes, Frank, can you interpret the image on the right? He's got two arrows. You got the radiology sign, right? This is a patient with Conn syndrome for sure. And he's got a right-sided nodule, but what about the left?
The left side
Is also abnormal.
also
Yeah, so which side's causing the problem? It's probably the bigger tumor, right? Yeah. And that's exactly what this one shows. Even though the bigger tumor is on the left side, this patient's right adrenal is causing the problem. And that's how we interpret this. So 4 is the number you need to know. The aldosterone to cortisol ratio on the dominant side of the non-dominant side has to be greater than 4. Of course, it's debatable, but for the boards, it's 4. And then things that help seal the deal is if the non-dominant aldosterone concentration to the IVC aldosterone is less than 1, which is right here. So the non-dominant on the left is relative to the cava is less than 1. That's great. It means the contralateral gland's been suppressed. And if the aldo to aldo ratio, dominant to non-dominant, is greater than 3. So that's what we see here. The right is like 405,000. The left is 15,000. So definitely greater than 3 on that side. So this constellation is probably the right side that's causing the problem. And when they did adrenalectomy on this person, he had two smart, tiny aldosterone levels that was causing it. The left side was totally benign. Controversies. How do we define it? What's the best number? We don't know. Turns out, depends on where you get it done. Whether you need to stimulate with ACTH, again, don't really know if it's necessary. Depends on the center where you do it. And whether you need to do it at all. So reasons for doing it is it can change your management. Like that last patient, if you just took him based on CT, you would have taken out the wrong adrenal. And certain people think that up to 30% of patients, their management will change based on the results of adrenal vein sampling. However, when this was studied in a multi-institution surgical study in the Netherlands, because it's always done there, when they base management off CT versus off MRI, it turns out long-term outcome exactly the same between the groups. So just know that it's controversial. But for your boards, yes. If they're young, they have appropriate symptoms, and they have a nodule on CT. So young people generally don't have ugly looking adrenals, but if they have one ugly looking adrenal and they're young, age less than 40, you can use the CT. If they're older, particularly if both adrenals don't look totally normal, then get the sampling. And then adrenalectomy maybe helps, maybe doesn't. It's not as good as we thought it was, based on biochemistry at least. It will resolve their biochemical abnormalities in less than all patients because they have longstanding hypertension. And long-term cardiac morbidity does not seem to be much different between medically managed and adrenalectomized patients. Consistently, though, it reduces patients' blood pressure med requirement. So they go from 4 to less than 4, or from 2 to 1. And their only chance for complete clinical success, which is normal blood pressure off meds, is with adrenalectomy. So when you're counseling patients, that's what we tell them. Like, the only chance to get off blood pressure meds is if we do adrenalectomy. That said, less than half of the patients that get adrenalectomy are all the way normal when you're done. Boop. Management, already did that. So prep for surgery, Aldo, localize, then get their K ready. Pheo, all right, so this anesthesiologist nightmare. They get boarded on this one. So what do I have to do for Pheo, Andy or Shay? Yeah, plus beta block, then volume load. So like 5 days leading up to surgery, give them a bunch of Gatorade and salt and pickles and stuff like that and say, eat this and drink a lot of water. And then even then, despite that, you're gonna have huge blood pressure swings in the OR. So Phil, did we do that one, the open one? Oh yeah, remember what her blood pressure did? She was alpha block for 3 weeks, like appropriately alpha block for 3 weeks. and she loaded for 5 days. And then how did her blood pressure do in the OR? Yeah. Just making a cut. She went 250s. And then after the tumor came out, they were flooding her with pressor and volume. So that's even someone that's been appropriately managed. So anesthesiologists love this. It's like, got a FIO. And like, there's like 3 anesthesiologists in the room, like, we're going to do this. It's going to be awesome. And then it still sucks. So if you can't get them, so if you're alpha blocking them, you're beta blocking them, what other med can you use? I'm running M&M. We can go quickly. It's fine. I know we're a little over time. This is like total lab site stuff. Tyrosine. And that inhibits tyrosine hydroxylase. So you just interrupt the entire catecholamine synthesis pathway. Adrenal Cushing's. The thing you do about operating on adrenal Cushing's is these patients are fragile. You can break bones just positioning them. So you treat them very carefully, like kid gloves in the OR. Their bones are so brittle from their Cushing's disease, particularly if they have overt Cushing's. So be really careful when you're operating on it. And then ACC, stage them. It's a cancer. Stage them, get some tumor markers, and then try to take it out. Let's see, approaches real quick. It's a surgery talk finally. There's different ways of getting at it. On the right side is our standard open adrenalectomy. So particularly for ACC is what we're thinking about. If you're doing an anterior approach, this is the modified Mercucci incision. It's also called the trapdoor incision. We go down the midline and cut across to the right or the left, depending on where the adrenal is. On the right side of the picture is the first description of posterior adrenalectomy, which was done for mostly for Conn syndrome. And the bottom picture is how this is a urologist that did, remember, a urologist did the first one. This is probably not endorsed by general surgical societies. This is the so-called manipulative maneuver for getting the adrenal out, which is avulsing it. Pinching the vein and pulling out the gland. This made it into a surgical journal, I'm saying. Minimally invasive. We get the patient up on their side and we put ports along the rib cage most often. And then retroperitoneoscopic or the posterior approach. It's called the quote unquote prayer bench position. And you put your ports beneath the 12th rib. We don't take out the ribs anymore unless it's like there's a compelling reason to do that. This is what it looks like. And so the posterior approaches, I haven't had to do these since I've been here. I've been doing anterior open approaches because I have a very weird niche practice right now, but Clifton and Vreeland do these. And what you're looking for is this kind of triangle of fat in the middle with the kidney down, the peritoneum pushed up and away, and then whatever your other retroperitoneal structures are off to one side. So you're coning in on this triangle in the middle. And there's a lot of selection that goes into that. But it looks kind of weird, and then you're carving out fat. The adrenal fat looks different from the retroperitoneal fat, and unfortunately, you're like, well, how do you tell? It just kind of looks different. Yeah, when you get there, it's golden, and yeah, there is. And the patient selection for it, we do off CT. Sorry, I know we had the hormones are important because like all of the stuff is on the front end. Really, once you get in there, every adrenal operation is what, Phil? What is the key maneuver? What is the key step? Yeah, getting control of the vein. Yeah. So adrenal Cushing, so a couple post-op things. If you're doing adrenalectomy for Cushing's, subclinical or clinical, they are going to have adrenal insufficiency post-op, almost every single one of them. And it lasts up to a year and a half. So these patients, you prep them to go home on steroid. And you also prep them to go to their doctor if they have any febrile illness post-op, saying like, I need steroid. So we had, Michigan, everybody went home with a card that they had to carry in their wallet. So if they had to go to any ERs, like here's my ER card, it says I've had an adrenalectomy, give me steroid if I'm sick. Some people, we gave them medical alert bracelets for the same thing, but it takes up to a year and a half to get better. And then this is like the standard instructions for their steroid replacement. And then you have a friend in endocrinology, they test them, they give them ACTH stimulation about 6 months post-op. And if they pass that, then they take them off steroid. But just be prepared for a long haul with Cushing's. With cons, the con suppresses the other glands. So they go from hyperaldo to hypoaldo. And so you see hyperkalemia, and you can see diuresis from that. Hyperkalemia bad enough to treat in about 5%. And then recovery times, biochemically, they're normal by the time they leave the hospital. So we get an aldo level before they leave to confirm that we got it. And their renin takes a lot longer time to adjust, and about 1 to 3 months for their long-term blood pressure situation to settle out. That's all. I have some cool cases first. Just here's this person. Don't need to worry about that. And then this person. Okay, real quick. Connor, 30-year-old man, hypertensive emergency. He got admitted with like respiratory failure, flash pulmonary edema. What do you think's going on? Yeah, it's a PHIO. And that's a PHIO crisis. Thanks. I know we went over time, but there's a lot of hormone stuff you need to know if you're going to be managing these patients.